and thank you all for spending your evening to hear from me about some research that I've been doing. I think I'm trying to condense somewhere around 12 or 14 years worth of projects into one teeny little talk, and then sort of wrap it up with the stuff that I've been thinking about for the past, say, 9 months on a newish project. Katie mentioned the Digital Twin Neighborhood Project, and I'll talk just a little bit about that one. This image was my own handiwork. It was like in the proposal for the project. Those of you who have been to Cleveland will recognize the skyline. It's my photo that I then took a skeleton of to make it look really nice. The title here is meant to be a little bit provocative. What are we going to do about social determinants of health and aging? There's a little bit of a move in there that is sort of, I'm misleading you with my title maybe a little bit, and hopefully you'll see where I'm going with that by the end. So I have so many amazing collaborators over all these projects. I'm only going to highlight one person in this list. His name is Paul Gunselis. And it's because he's a Miami University graduate, and he saw in some list and asked me in a meeting this week, "Are you giving a talk at Miami?" I'm like, "Yes, how did you know?" And he said, "Because I went there, and I read the news." Okay, that was really nice, so thank you, Paul. He currently works at Cleveland Clinic, and he's a data scientist biostatistician who I think maybe developed some of the R code for one of the maps in here somewhere, but I'm not gonna give him too much credit for that. I have disclosures. I work in the School of Medicine, so I am founder of a spin-off software company from one of my prior projects, and I have royalty agreements with some publishers that occasionally pay me a little bit of money for books that I've written. So what am I really trying to do today? I really am trying to come up with a way to discuss some pathways to a more socially responsive healthcare system for us. But I think there are pathways some that we're going down now and some that we haven't quite explored yet, is how I would frame this. And I'm going to start with a proposition that maybe some folks agree with and maybe some folks don't, but I think is relatively under-recognized, which is that neighborhoods have a critically important influence on health over the life course. This is the neighborhood I stayed at in Mexico City in June. It's really, really deceptive. So it looks sort of nice, right? The general impression is it's really, really nice. If you really look at it, you'll see something that's maybe a little bit unnerving. Also, I Airbnb'd in this blue building. Do you see the unnerving thing yet? Some people are nodding. There's razor wire over the green wall to the place, right? So and this is probably the least offensive picture that I tried to make it the most. So it's this beautiful tree-lined green street. But at the same time, there's razor wire everywhere. You cannot. Security is a real thing here. So there's this sort of imbalance, even in the visual aspects of this particular neighborhood. Honestly, I stayed there really long. I felt super safe. I was going out at night. It was totally fine. But I think there are things about neighborhoods that are both visual and data-based, but that maybe are less visual. And hopefully I'm going to share some of those with you today. This talk is about social determinants of health. I've been using this slide for a really long time. And not because I think social determinants of health research is increasing, but because I think the concept of this chart is a little bit ridiculous. I understand completely what Paula Braifman and David Williams were doing when they're look, this is increasingly important. But the idea that, okay, there was only one paper about social determinants of health in 1989 is a little bit misleading, right? No, all the papers about society were about social determinants of health in 1989. We just didn't call them that yet, right? This is a difference in the vocabulary that we're using. And I think that this increase is largely attributed to an adoption of this vocabulary in places like the one that I work, which is a medical school and a hospital, which have a big pulpit and a strong voice and can talk about things really loudly, and a lot of people listen. So I think this trend is increasing exponentially still, that curve is still happening. This is probably the most commonly viewed model, this Dahlgren and Whitehead. It's a version of an ecological model. I put it up here just so that you know that I know about it. Not for any other reason. I've been thinking about things more along the lines of a sort of bioecological developmental systems theory, which is sort of a synergy thanks to Dr. Kennedy. We spent like a whole bunch of time talking about this in perspectives in gerontology this morning, and I learned many things from the folks in the class. I don't think any of these visual things are good, and one of the reasons is that it's really, really hard to combine ecological layers that go all the way from molecule and cell up to neighborhood and society and have a time dimension in there visually. Like, they just don't look super great, but on the other hand, they're managing a mountain of complexity, and I think so the main takeaway here is like there is a mountain of complexity when we begin to look at social determinants of health, particularly when it comes to neighborhood. This figure, I don't want to spend a ton of time on, but I think it's the best one that says, what are we actually doing about social determinants of health from a theory basis? I dropped, the call it is mine, not from the National Health Service. And it really shows that like most everything that we do that's focused on social determinants of health in our care system focuses on this very individual level set of influences. That isn't to say that we don't do the other things, but we tend to focus more on these individual level experiences than on other things. And I'm going to give a few examples. This is a screenshot from the social determinants of health screening tool in the electronic health record at our hospital. We've now screened somewhere around 200,000 patients in the past 4 or 5 years. So we asked them about all the stuff that's on here, their financial resources, food insecurity, transportation, housing, intimate partner violence, whether they have internet in their home, whether they're having trouble paying their utilities. We asked lots of questions about this of many, many, many patients, many times. And when you're a clinician, you don't deliver those questions, you get the results. Like a lot of people fill them out on their phone before their visit or in some waiting area, or a medical assistant asks them. And I sort of have a colloquialism for this chart, which is I sort of call it the wheel of shame. It doesn't feel super great. It's the only thing we do in the electronic health record that really portrays this. I don't love it, but it is in there. I think there's been a recent revision, and maybe it looks a little bit different in the version that was released recently. But it's sort of like a one-look glance at what a particular patient's social needs are. We also have diagnostic codes where we can code for, although most of the time we don't attach codes to these things. We can code someone as having homelessness, right? There's a Z code for Z59. When we look in our data, really probably less than 5% of the people who are homeless have been tagged with the code, because it's not something that care clinicians, particularly medical doctors, are used to coding for. It's also not something that we get paid for yet. So we don't really get paid extra yet if our patients are homeless, but maybe someday, and there's an encouragement of healthcare providers to code for these things. It's also not actually a medical diagnosis, right? Like you do not need a medical license to determine that a person is homeless, but we have created a medical diagnosis of homelessness and a code for it that we can record in the EHR. Those of you who do Medicare research should know that these codes are also available for you in the Medicare Current Beneficiary Survey, and they're increasingly utilized and useful for your projects. They keep going all the way down through food insecurity, poverty, low income, like lots and lots of Z codes exist in the data now. There was a project at our health system that looked at the data that we were collecting relatively soon, so this is now a couple of years ago, and they went through this process diagram of like, well, here's how it really sort of happens. We screen people, did they have needs? They consent to a referral. Sometimes they don't. Did they actually get referred? Does the service agency in the community actually accept the referral? Sometimes they do, sometimes they don't. And then is there some outcome? Sometimes I give this as a little bit of a quiz. So like if you thought about like a population of 100,000 people, how many of them who we screened in the first place, what percentage of the 100,000 do you think we actually address their need? I'll let you come up with your own internal guess, and you can see if you were high or low. So the answer here is misleading because if you look at the resolve percentage there is listed as 27%, but that's 27% of the accepted referrals. So the number that you actually need to look at is of the 5,741 patients who were screened, 98 had a resolved referral, or of those who had food insecurity, of the 988 who screened positive for food insecurity, we were able to address their food insecurity 98 times out of 988 times. So we got about 10%. But out of the total burden to the care system of processing all these questionnaires, and then the burden that I care about the most, I wrote this nice little perspectives piece in AMA Journal of Ethics last year. So, imagine yourself answering these questions at your doctor's visit. Have you worried your food would run out before you had money to buy more? Were you unable to pay your rent on time? And this one, have you been humiliated or emotionally abused by your partner, right? So you're there, maybe you're getting your blood pressure checked, or you're just trying to refill your medicine for whatever other problem you have. And these questions are questions that we want you to answer. We want you to answer them every year. And for many patients, that does not feel super good, right? I cited the data from that paper. But I think there is this quote from what I wrote before that I really want to read here. The tables and figures on the social determinants of health can seem like a disservice to the truth of the challenges faced by our patients. How can we confront these challenges while preserving the dignity of patients, right? Because I think there's a little bit of a challenge that if we're not following through for 90% of the people who have a need, and the vast majority, 95, 98% of the people who we screen, we're not actually doing anything with the information that we're providing them, then what is the burden on the dignity of the persons that we're serving from the way that we ask and how that we ask? And is everybody who's actually asking these questions doing so in a culturally humble and appropriate manner? And is this really the best system of investment for addressing these social needs? Certainly for the family that is not having food this week, that did get a referral and now has food, it's really a value, right? You have food because of this program, you really are appreciative of this program and it's working very effectively. But there are other places. One of my favorite examples is that when the referral fails because someone's not eligible, right? Because they don't meet, we're going to get you signed up for the SNAP program. I was kicked out of the SNAP program. Or we're going to refer you to the Cleveland Housing Network. They evicted me twice in the past 3 years, right? So I think that's really, really tough. So sometimes our public institutions and our referring institutions have damaged the lives of our patients. And we're asking them about their needs and referring them back to the places that damage them. It's maybe not the best model of care for social determinants of health. But I don't want to spend too much more on this. This was a very brief critique of what we're actually doing a ton of right now. And I want to talk more about the things that I think are actually driving outcomes that we might do something about. So how can we go beyond that? I'm not going to read all these nice questions. So I want to know what happens when we look at neighborhoods. And I was trying, as I was building this, I was reflecting, why do I care so much about neighborhoods other than that I live in them? And I thought I really did. When I was a little kid, I was a huge fan of Mr. Rogers. This is a very embarrassing component of my biography. My dad likes to tell this story. He was like, you really, really did like Mr. Rogers. I'm like, how much, Dad? Well, you used to, when it would come on and Mr. Rogers would sit down and take off his shoes and change them and put on his sweater, you used to say, I love you, Mr. Rogers, which is tough. I can't believe I shared that with you, but I do think that right? I want it to be a beautiful day in people's neighborhoods. I actually do want that for all of you and all of our neighbors. And maybe that's a little bit of the spirit of my talk. And I don't think it's wrong. Pittsburgh's not that far away where this was filmed. So that is baked into this talk a little bit. So I said this already at the beginning. I think the places that we live are unequal. and the foundational influence of place and health is generally underappreciated in science. And I think like that's where I'm going to go from here, and then we're going to sort of hopefully wrap up with some of the stuff that we're doing to maybe change course on that. This is a little sort of simplification of a confirmatory factor model of the area deprivation index. Our team was the first ever to do a confirmatory factor analysis of the area deprivation index, despite the fact that it's used a lot. We have a nice little R package. If there's R coders out there, it's called Sociome. You can use it to get the area deprivation index for any year of the American Community Survey. Most of the papers that I talk about where we're using area-based data to estimate area deprivation, we use that package now. It's great. Also, if you break it, I really want to know. This is from Amy Kind, whose work has really popularized it. Gopal Singh sort of developed this a long time ago, maybe 30 years ago. Amy Kind had a nice paper where she used Medicare data. She's at University of Wisconsin to predict 30-day readmission in hospitals. This is a nice map of Ohio. I think this is Tableau or something. And you can see like there's some stuff that's going on that's not super great. The zoom in, the triangle there is University Circle where Case Western Reserve University is. And it's sort of this like blue island in a sea of red in Cleveland, which really characterizes a lot of what happens in our urban areas. So I'm going to shift gears and like really go really fast, like blazing fast through some empirical results, because there are so many fun things I want to tell you about that relate to neighborhoods. So this was our first project on using electronic health record data. So many years ago, we discovered that we could use addresses in the electronic health record to geocode patients to where they live and then merge that data with area-based measures from multi-sector sources. So we started to do that with this project on cardiovascular risk. This is an older view of our data from that study, which shows you just by age decile who is in there. And you can see like there's some shocking stuff in here, right? There are like 80,000 people over the age of 80 in 2016 alone, right? Would you like to do a study of 700,000 people over the age of 80? Because I have a data source that can do that now. And we know so many things about everyone in here. We know their medicines, their lab results. In addition to where they live, we've merged it with the Ohio deaths data, so we know if they died and when they died, and we have all the data off their death certificate. We also have merged with their birth certificate recently, so we know where they were born and who they were born to. We know what images we've taken of their body, we know which days they were in the hospital, and all the measurements we've taken on them on the days of their visits and everywhere in between. One of the reasons we can do this is because Cleveland is a bit weird, and really most people, about 90% of people, receive their care from one of three healthcare systems. Two of those are represented in this data, where I work, Metro Health, and the other system is Cleveland Clinic. So when we bring those together, we cover roughly 80% of people in all the neighborhoods. And we do that going back for roughly 24 years. And so the blanket of studies I'm going to show you use that geocoded data. So this was the first one. It's on cardiovascular risk using a cohort from that data. And here what we found, it's a smaller cohort of just 110,000 people. Their eligibility was we gave them a cholesterol test and then we followed them for 5 years. And then we just estimated we looked at which people had heart attacks and strokes or died from heart attacks and strokes. And so this is our representation of socioeconomic position in our neighborhood. And this is our representation of who has heart attacks and strokes. They look almost exactly the same. The finding here that I keep getting stuck on, even 6 years after writing this paper, is that neighborhood socioeconomic position count alone, on its own, single variable, accounts for 32% of the variation in who has heart attacks and strokes in our region, compared to 10% by the PSERM. The PSERM is the pooled cohort equation from the American College of Cardiology. Some people might know it better as like the Framingham risk equation for heart attack. So it's an estimated risk of heart attack based upon largely clinical and demographic measures. And none of those are the same as neighborhoods. So what we're saying is we're 3 times as good at predicting heart attacks if all we know is somebody's address than if we have their blood pressure, lipids, diabetes status, age, and a few other clinical measures. This paper is now cited in the American Heart Association, American College of Cardiology guideline on treatment of cardiovascular disease. And the idea here is that we need to take in social determinants in our decision-making about whether we give someone a statin or an antihypertensive early on in life due to their risks which may be elevated by their neighborhood. Unfortunately, there's no actual guidance on how to do that. They just say, like, maybe you should take into account this contextual stuff, which leaves doctors with, like, I don't know how to do that, but okay, thank you. So we then did another similar study where we looked at a bunch of smokers in our own hospital at Metro Health, so about 40,000 people who were smoking. And we looked at who got lung cancer, and we looked at that according to where they lived in our region. And we found about a 37% increased odds, unadjusted increased odds of getting lung cancer among all these people who smoke just from living in a disadvantaged neighborhood. The other interesting thing that we find in this particular analysis is that when we adjust for neighborhood social factors, the disparity between groups in the incidence of lung cancer that is typically seen in most studies by race and ethnicity fully disappeared. We're the first study to show this, that really socioeconomic conditions are driving lung cancer incidence, not race or ethnicity in our region. As we were coding all of that data and using addresses, there were a lot of people in the data who did not have an address, or their address was 123 Main, or they listed our address, which is 2500 Metro Health Drive, which is the hospital, or sometimes somebody just typed in homeless. And we thought, oh, what do we do with, like, we can't like geocode them to their address, they don't have a home. But then we thought, like, oh, but there might also be some addresses in here which are weird. So we did a simple, our health system is a safety net care system. We did a sort of the frequency of the address column in the data. And what we found that is in 24 years at Metro Health, a single address, 2100 Lakeside, was the most commonly recorded address in the history of our healthcare system. We had roughly 3,500 patients at one address. This is a Google Street View taken of 2100 Lakeside. It's a men's shelter near the lakefront, and these are the men who are lined up to get in before it opens at 6 p.m. so that they have a place to sleep that night. And the Google Street View van just happened to be driving by and take this lovely picture that anybody can go see on Google Street View anytime. These gentlemen's faces are, I guess, blurred out to protect their privacy. Interestingly enough, I know who they are because they are in the electronic health record data. We compared for those folks all of their clinical diagnoses. This is just a brief list by the Elixhauser. And what we did is we looked at persons who are homeless, and then we looked at persons who were not homeless. So they had an address, a continuous address recorded in the EHR, but those folks lived in an area of high socioeconomic disadvantage. And then we looked at folks who were not homeless and lived in a more privileged, socioeconomically privileged neighborhood conditions. And we just compared the prevalence of these health conditions. So, it's roughly, 500,000 people over a 10-year period. And you can see this massive burden of substance abuse and mental disorder among homeless persons in Northeast Ohio in our electronic health record data. Really sort of 3 to 4 times, sometimes 5 times the burden. And then you see other stuff that's kind of interesting in here, which is that, like, high blood pressure is a little bit even, right? Like there's a difference, but it's not a huge difference. And then this is another project we did with a med student. This guy's name is Jimmy Yao, and he was interested in, well, do these neighborhood conditions, do these things affect what happens in the early days of life for the patients in our health system? And so pediatricians were interested to see, like, well, which kids turn out for their recommended visits in the first 18 months of life. And so this is a plot of how many of the first 8 visits they miss. So higher is worse on the y-axis. And again, across the x-axis are the area deprivation index quintiles. And what you can see in this nice violin plot that he made, that the burden of children missing their first year of life visits is much, much higher for persons in these high area deprivation index neighborhoods. So we started to ask on our team, well, what happens is it just like the clinical and disease outcomes, or is there stuff that's beneath that we can detect, right? Like, could we, and this is in part motivated, we happen to have a guy on our team who was a cardiac interventionist who at the time was getting his PhD in immunology, immunology and was really interested in cell science, and said, you know, like, do you guys happen in the lab results to have a complete blood count? A CBC is like, if you've watched like a medical drama, like in the ED, like if you've watched a medical drama, one of the things that often happens is like, you know, you'll hear like they're rolling some patient in the OR or in the emergency room, you know, like, give me a CBC and a Chem7, right? Like, most of you have probably had one in your life. We order them at well person checks, we order them at surgery, we order them all the time. When you get COVID, like, we order a CBC. On the complete blood count, there's some stuff that we generally don't look at because it's not really clinically diagnostic, but that could be indicative of subclinical changes in your body that might be things that aren't so good. Two of those things are your absolute lymphocyte count, so how many white cells you have in your body. And then the other one we look at is called red cell distribution width, which is a simple measure of the variation in the size of your red blood cells, right? Like, how big are your red blood cells? And if they're non-uniform, that's generally not super great for you. But that uniformity varies across the life course. Like, little babies have like pretty high RDW actually, and then it sort of gets better as they age. But then in adulthood, it's a certain number, but then when you become much, much older, it starts to creep up. And here what we found is if you have both high RDW and you have high C-reactive protein and you have lymphopenia, so you have few white cells, you're far more likely to die, actually. Like, you're from all causes. This work was replicated in about a dozen COVID studies, and they found that this distribution of these three markers off the CBC made people far more vulnerable to death from COVID. The really interesting thing that we found is that when we look at those indicators by neighborhood, so this is a plot of red cell distribution width stratified by age for all those same neighborhoods in Northeast Ohio by the area deprivation index quintile. This is just a few years of data, so it's only 245,000 patients. And what you see is if you look at the left side of the chart and compare to the right side of the chart, so if you say take the bottom of the red bar and the top of the red bar, what you can see is like roughly a 10 to 20 year difference in the subclinical aging of red blood cells, right? So your body is manifesting this dysregulation of your red blood cells based upon, chiefly, in our view, where you live, which seems not great when that value is also associated with your likelihood of dying from multiple things. So we then started to look at, and Sam was telling me that he actually read this paper that was recently published in Du Bois Review, which makes me feel really bad for not including more slides on it. So we did some work looking at data and redlining maps from the 1930s and comparing that data with the distribution of illness, disease, death, life expectancy, and the burden of socioeconomic conditions in present-day neighborhoods. The visual depiction is the best, right? It's the same neighborhoods, right? This is a map that I made in R in 2020 using the area deprivation index at the block group level, and the correspondence between those neighborhoods is actually a little bit shocking. So now I'm going to tell you about some work that we're doing now that pertains to digital twin neighborhood. We're calling it provisionally Health Equity Achievement for Land Index, a health data informed approach to improving vacant land. And so one of the questions we're always left is like, well, if this is our grim reality, how do we do better? This is one of our first projects looking at that. It's in progress, and by in progress, I mean we don't even really have a funding for it yet. It's a spin-off project of Digital Twin, which I'll also talk about. So I showed you this paper. On lung cancer. So we've got cardiovascular disease, lung cancer. We also have kidney disease. We also have triple-negative breast cancer, and we have dementia that we've made these same predictive models where we see the powerful influence of neighborhood social conditions in our region on outcomes. If I haven't convinced you of that, you can come see me later and I will work harder. This is from the Alzheimer's disease paper. This paper looks shockingly like that redlining map. This one actually hurts me a lot. If you look at the 10-year risk, the 10-year risk of Alzheimer's disease is functionally double. This is electronic health record data, again on 253,000 Northeast Ohio older adult residents. I really do not like this map. It is one of the most heartbreaking things I can imagine. If you think about the burden on communities and families of an increased population of elders who have dementia, like this is one of the most heartbreaking things that I can imagine. We see this across all age cohorts from 60 to 80. There's a wide gap in neighborhood socioeconomic status and incidence of dementia. And we see it for both men and women, and we see it across all racial and ethnic groups. So we're back to where I showed you neighborhoods have critically important influences on health. This is a really nice neighborhood. So I stayed here in May in Berlin when I was presenting on the HEAL Index stuff, and I was like, wow, if neighborhoods were like this, I think people would live longer. There's like ample mass transit, there's healthy food everywhere, there's walkable streets, there are bicycles, like folks can do stuff right in neighborhoods. So we did this thing in our health system to better understand the health of our local neighborhood, where we walked through the neighborhood with some of the folks who live across from the hospital. The neighborhood there is called Clark Fulton. The socioeconomic conditions are in those maps. I guess I would say they're in the red. We talked to people in whatever language they wanted. We actually have the fastest growing population of Spanish speakers in the state of Ohio, lives in the Clark Fulton neighborhood. They're mostly folks who are from Puerto Rico. These interviews were about 30 minutes. We walked around. If it rained, we took the car. There were a few folks who were older and disabled, and we just talked to them on their porch because they didn't want to go very far. And then we asked them how it was going. Here's a picture of how we went through the neighborhood. And I just want to summarize really quickly with 2 quotes. So there's a lot of terrible sidewalks. There's a lot of really bad sidewalks. So people use them as much as they can. Yeah, so I mean, there's not really parks to be used, especially in this area. So I mean, you'll see a lot of kids outside just riding bikes on the sidewalk. This is particularly ironic because I was doing this interview, and as she's speaking here, this is not in the transcript, I legit tripped on the sidewalk. Like, I'm clumsy, but that actually happened. The irony of that is not lost on me. But it wasn't only bad stuff that people had to say about their neighborhood. And I think this is really important. When we asked what is important to you about the neighborhood, there were more than one person who said, I really want to take you and show you something. And they took us to this alley, which I admittedly the first time wasn't super jazzed about. Like, I want to take you to the alley. Like, okay, let's go. The reason is because people from the neighborhood created this beautiful mural, and they told us about the potential that they see in their neighborhood and how they can see it changing for the better, and that there are people there who care and are going to make changes in their neighborhood. This is a really beautiful, I like to look at this as often as I can. So in part in response to this, and we've also on Digital Twin, we've been conducting a series of community engagement studios in neighborhoods asking how we should use all of our neighborhood data. And one of the things that folks have told us is they want us to take an asset-based perspective. One of the community-based organizations is a group called the Western Reserve Land Conservancy, and they asked us this very specific question, which it's always nice to get specific questions. The question was, can you help us find a way to use health data evidence to make decisions about the redevelopment, regreening, and repurposing of vacant land? And of course I said yes. And then I said, why did I say yes? I have no idea how to do that. But in general, I think we can use neighborhood data and health data as a launching point for improving the health of our neighborhoods. So we don't just have to use it to pathologize and understand the bad things of neighborhoods and understand where disease comes from. But however, there are some people who still think that neighborhoods don't matter, and they just haven't been to my talks. So we have this new project called Digital Twin Neighborhoods. We know that combining data across health systems is great and can produce these huge samples, which allow us to have, there are so many, I can look at all these questions in little micro cohorts, right? We can look at every 5-year age group within every sex and every racial and ethnic category and still make really precise predictions because the sample sizes are so big. The problem that we encountered is that doing that is really hard regulatory-wise because I know everything about everyone. right? And so privacy is very important to us. So I can't just give all of you grad students the keys to the data, right? Like, because of course everyone wants that, right? Like, oh, can you test this? I really want to do this, but it's very hard. So we came up with this idea that we could create a simulated version of the data, which would have fidelity to the real version and allow you to do that while simultaneously protecting people's privacy. I'm not going to talk about how we do that because in truth we don't actually know yet, but I am going to give this auto industry analogy, which I think is great. So if anybody is old enough to remember a guy named Ralph Nader who was complaining in the 1970s that cars were very unsafe, many people were dying in cars because we didn't even have a seatbelt law and we didn't even have rules and regulations on that cars should be safe. So then we had car safety laws that required cars to be crashed with crash test dummies, right? Because like, oh, cars are unsafe. We had policy first. Policy said, but then the problem was like, it's actually really expensive to wreck a car. You have to build the whole car and then speed it up really fast and wreck it. Right? And doing that over and over again is really hard. So what did engineers in the auto industry eventually do? They designed digital twin versions of automobiles. They don't wreck as many cars anymore. They just take a digital version of the car and smash it into a digital wall and use like representative physics and then figure out what happens to make the cars much safer. They still do crash some cars, but not as many. When it comes to neighborhoods, like it's really, like there's no experimental methods, right? Maybe we've had a couple. We've had Move to Opportunity, which is a great study some of you know about, but we're probably never doing it again. And it's just tough. Like we don't really do experimental studies on neighborhoods. So, but maybe digital twinning is a really great way to handle this problem. There are lots of benefits. I'll let you imagine most of them. So how does it work? Honestly, we have no idea. We're just like talking to people and developing the algorithms and testing them right now. But in the midst of that, people told us what they really wanted, which is that they wanted us to be able to use this data to improve their neighborhoods. So one of the first steps was, well, in order to do outcomes-based research from electronic health record data or simulated electronic health record data, we got to have some test of how good we are at it. So the first thing that we did is we developed a life expectancy model using only electronic health record data. So totally like pretending that we knew nothing about the Centers for Disease Control, small area data. We thought like, can we beat this model using only the data in the electronic health record? Actually, we can. This paper is due to be submitted next week. We have a really exciting way to do that now. The folks at the Land Conservancy, though, are dealing with this problem of vacant land. And it's easily stated by this particular sentence, which is that in Cleveland, Ohio, more than 30,000 parcels are vacant. This is one aerial view. So how could we create a health achievement metric for a neighborhood that would tell us if we did something to invest in these parcels, which investments would pay the most benefits for health for the people who live there in the shortest period of time, was essentially the question that they asked us, right? With the idea being there are 30,000 parcels. If it costs on average $5,000 to rehabilitate a single parcel, the city of Cleveland does not have the money to redevelop these, right? No single land developer has, like we can use the entire state of Ohio's infrastructure budget and we still haven't reached the point where we can redevelop these 30,000 vacant parcels. And in the meantime, our neighborhoods look like this, right? It's a public health emergency. So we came up with this formula that is basically just a product that we think works okay. But before we get to how that works, we had this paper that tells, like, first you need to determine how representative the data are from the electronic health record of the community. Like, is the data that the hospital has actually representing the people who live out in the community? There could be a lot of people who don't use health services. There could be people who use other healthcare systems. At one point, we had this group of Hmong Chinese who refused to get care. Even though we had like an Asia Services clinic, they would take a bus to New York City to go to their trusted care provider in New York City rather than see our doctors in our health system because they were, while we had Mandarin and Cantonese speaking physicians, we didn't have anybody who was culturally concordant with Hmong, so they would prefer to take a bus to New York City. So like maybe there are some folks in some neighborhoods who we're not reaching, and we need to find a way to do that. We have a nice paper that tells you how to do that. We think that we're right about how to do that. It's too much to talk about in a small talk. We also, once we figure that out, we need to decide like how to make a cohort of people, right? Like which people do we choose? In the cardiovascular cohort, we had a great tool for this, which is like, did they have a lipid test, right? Like, did we check their cholesterol is a nice way to determine, but for different questions, we might need different ways of assembling a cohort. There might be some other concerns, like did these people have a visit every year? Have they only had a visit 1 year? Have we only seen them in the urgent care? Have they only been in for a COVID test and we've never seen them again? Do they only come for virtual appointments? So we need to first derive an appropriate cohort. The next step is we need to estimate the area level disease prevalence. This one, as it turns out, is fairly easy once we've done the other two, right? Because doctors are really good at telling people which diseases they have. So now we know, like for each area in the region, who has what diseases. We couldn't have done this for any of those disease-based papers I told you about without this simple step. The next one is we estimate an area level preventive therapy ratio, T. So this is like among the people with a given disease, if there's a preventive therapy for that disease, what proportion of them had it? So this could be for an infectious disease, it could be a vaccine. For cardiovascular disease, it could be if they have hyperlipidemia, high cholesterol, then did we put them on a statin? If they have high blood pressure, did we give them an antihypertensive? Like you can imagine all the other permutations of preventive therapy. So we just want to know what ratio completed the preventive therapy. The next thing we do is we just multiply those two things, and it gives us a new number, which is a really interesting number as it turns out. After that, we can make some beautiful map because I can't count steps. We then repeat this for multiple neighborhoods. The step 6, we're going to use factor analysis to create an aggregate index with resulting scores of health achievement types for each neighborhood. Then we re-estimate the available scores based upon preference ratings from the folks when we walk through their neighborhood. So optionally, we can talk to people in a neighborhood and ask them which health conditions they're most severely concerned about, which things they feel a burden of, which things they would like to be alleviated of. And we can re-estimate the model based upon some set of prioritization and preference scores. And so our first analysis of the health equity achievement for land score, I used these two neighborhoods, and I did this on a napkin at an airport, so it's not super sciencey just yet, but we're pretty confident that this actually does work. So if we look at Midtown, you saw the picture, like almost all the land is vacant. There's not any vacant land in Van Aken. Like people will bulldoze a house and build a new house before there is vacant land. You have a low socioeconomic position and a high socioeconomic position neighborhood. But here's where it gets a little interesting, right? So the hypertension prevalence in Midtown is 64%, which seems like maybe not great. But in Van Aken, it's also 26%. But then the treatment rate is like really high. Like actually, if people have high blood pressure in Midtown, we are actually kind of amazing at making sure that they get on an antihypertensive. Like that like in terms of national quality scores for cardiovascular prevention, 88% is really doing quite well. In Van Aken, 75% is also doing pretty well, but it's worse in the high socioeconomic position neighborhood. So what that means is when we multiply those things, we get numbers that aren't quite what we thought, right? And so it's sort of like a little bit of a rebalancing of the burden of the condition on the neighborhood when we weight by the preventive therapy ratio as opposed to just the burden of disease. So in short, the breadth and severity of neighborhood influences on health warrant a positive and asset-based approach to improvement and development of area measures. We think this is like a super useful approach for policymakers. What the Land Conservancy actually wants us to do is to use those scores to tell them which neighborhoods should we spend which parcels should we spend $5,000 and improve. We think we have an approach for doing that, and we're really excited to try it out. We're working very, very hard to get funded to try that out. I think we probably, unfortunately, if we're going to do like a quasi-experimental design, which I said we couldn't do, but I think we actually can experiment with this now that we have all the data on all the people in all the neighborhoods. We can see what happens after we improve the neighborhood and the parcel. So I'll let you know how it goes if you're interested. Thank you, and I'd love to have some questions.